get started, I know everybody is really, really excited to get this information, and I especially want to thank Holland Healthcare, our sponsor, for bringing Dr. Flass to us this evening. So let me introduce you to Dr. Thomas Flass. He is a pediatric gastroenterologist and an expert in many fields when it comes to children's gut health, but also the upcoming author of the book, Feeding Our Children. What he's going to be talking about in that book, and I'll have him explain a little bit more toward the end of our broadcast, is really diving deep into the first 1,000 days of a child's feeding journey and how what you feed your child can impact them for a lifetime in terms of brain, gut, and overall immune health. So he'll be telling us more about that when we get a little bit farther into our discussion. But what I'd love to do right now is just, first of all, welcome Dr. Flass. I'm so glad you're here today. And I'm just so grateful you took the time out of your really busy schedule to help educate everyone here today about gut health in children.
Oh, thanks so much for having me. And we've chatted before, and there's so much overlap between our lines of business. So I think it'll be a great talk.
Definitely. I think you and I could talk about this for hours. We're going to have to be careful. We're going to try to chat about this for about 20 minutes, but everybody listening, go ahead. And if you have a question for Dr. Flass, please type it in. And by the way, Holland Healthcare is also going to be doing a giveaway tonight. So make sure you take a look at the rules for the giveaway. Casey out in Australia with Holland Healthcare is going to be informing you all about that. So let's go ahead and get started with 5 reasons your child may not be trying new foods, and it has to do with their gut health. I know, Dr. Flass, one of the things you wanted to talk about is just dysphagia, however you like to say it, and how that can really influence a child's willingness to try new foods. But from a pediatric GI perspective, what do you often run into when kids have difficulty swallowing? What do you tend to see most often, and what would you like to share with us on that topic?
So I think especially when it hits in that toddler age, right when they're looking to expand their diet and try new foods, is when we see a fair amount of this arise. And so it could also sort of have stemmed from the really spitty baby who sort of really didn't necessarily get over being really spitty. And then when it came time to start adding solid foods, they, would maybe do okay with purees, but things with more texture, they're having a hard time, maybe some more choking, gagging, coughing, and having some difficulty with that. So then we might see them months or, a fair amount of time later, and you realize this child is relying on only still purees, and they're well past their first year of life when they should be eating a lot of table foods and reasonably safe table foods, but solid foods, or they're still relying heavily on the bottle and milk and things like that. And you go back and get the history and realize that they were having all these choking, gagging problems. Maybe they're a really spitty baby, and they got to a point where they're just food refusing, or they just were not anything with texture. They just weren't having it. And it obviously is really stressful and difficult for the parents. And then you kind of need to do definitely more of a workup to find out why that is. And there's a couple, I think, key contributors for that dysphagia that we're seeing more and more of all the time. And one that you and I talk about a lot is EOE, or eosinophilic esophagitis.
Right. Can you just tell the audience, that is such a big word, eosinophilic esophagitis. What does that really mean? An eosinophil is a white blood cell.
Correct. So they're the allergic cells. So I usually think their jobs in the body are to either fight parasites, or they have to do with a lot of allergic reaction type of things. And so they're the same type of cells that get revved up if you have asthma, but they kind of a lot of times fall into that what they call atopic triad. So people who may be predisposed a little more to EOE might be the either kids with family history or even personal history of asthma or eczema, things like that. But there could be no history of that either. But these eosinophils, these allergic cells, will in EOE get lined up in the esophagus, cause inflammation, pain, and also food sticking. So when they go to swallow things with a little more texture, the food can get partially stuck, which we've all had that happen. It's not a pleasant feeling at all. And if that's happening all the time for this child, kids aren't stupid. If something hurts like that, they're not going to do it. So over time, they'll turn into these food refusers. And you can think it's a behavioral thing when really that behavioral thing had a clinical origin, a pathologic origin. that sometimes can take a long time to figure out.
Yeah. And so what's the youngest you typically see EOE in, or does it vary according to where you live in the country, or what do you see there in Montana?
I mean, we see quite a bit in Montana, but as you know, Colorado is sort of like an epicenter in a lot of ways because it's one of the top research programs in the country for pediatric EOE. And I was lucky enough to train down there. So there's a couple docs, Dr. Ferruta, Dr. Atkins down at Children's Hospital Colorado that are big time researchers into EOE. But really, I think it's all over the place, all over the country that this disease is, which was really unknown about 40 years ago, is now something that it's almost every week I diagnose somebody new with this disorder. And we'll diagnose as young as 9, 10 months if it's a child who's having a lot of vomiting issues.
Really?
Diagnose a fair amount of toddlers, but we also diagnose a lot of older kids who may have been having some subtler symptoms for years, and then they end up in an ER with a chunk of steak or chicken or some other food lodged in their esophagus, and they can't get it out, and then we have to endoscopically remove it, and then while we're doing that, we discover that they have usually pretty significant eosinophilic esophagitis, or EOE, that was causing these symptoms for a long time.
Yeah, and I think it seems like, at least according to appfed.org, that the numbers are on the rise. And I don't know if just over the years we've gotten better at diagnosing it or exactly what the story is, but that's really interesting to me that you can diagnose it that early in infancy, really. So that's fascinating. And in my book, Raising a Healthy, Happy Eater, we talk about eosinophilic esophagitis because I know Dr. Ferruta here at Children's, and I know he's a friend of yours as well. And it's just something that I have always wanted to educate more parents on because they aren't aware of it. Another thing that comes to mind, though, that I think most parents are aware of is something a little bit more common, which is constipation. And I was wondering if you could talk a little bit about that. We're going to talk about pooping now. What does constipation have to do with your child's willingness to try new foods, especially from a GI perspective?
You think of it's on the other end of the field, so to speak, but we call it the no vacancy rule. So if the child is having a hard time passing bowel movements, or if they're a withholder, as some children are in that age when they're starting to get near potty training and things like that, or any number of reasons can cause the constipation. But when the colon is full, it'll actually send signals to the stomach to not want to empty. And the extreme version could cause vomiting, but really it's more like just, I think, a chronic fullness feeling where that child is just, they have a lot of poop inside their colon, and then that signal goes to their stomach, and they're not wanting to put more food down when there's no vacancy down for that food to get processed and move down to their lower intestine. And sometimes if we kind of get these kids pooping better, then it can make a huge difference in their appetite and willingness to feed. And it sounds really like simple and kind of silly, but it if somebody's significantly constipated, it can be a game changer.
It really can. And constipation too can exacerbate reflux because we're just a system of pressures and valves from here to, frankly, the moment you flush it away. And so if you're stopped up in one area, the pressure is going to go up. Am I explaining that well?
And delayed gastric emptying, you can actually have some slowed stomach emptying, and that food just sitting in there longer. So if the longer food sits in there, the more it's likely to reflux, and the pressure can kind of back up. So, and then you kind of clear the playing field, and a lot of the issues can potentially resolve.
How long does it take if you give that child, under your guidance, an enema or Miralax or whatever treatment you decide to use? Does it take some time for that intestine to essentially go back to a shape that would help with that peristalsis? Or because I've heard that it can actually kind of be stretched out for a while if this has been a chronic condition.
Yeah, and in the extreme versions, you can get what's called megacolon, which is a really dilated colon, and some of the stretch out colons can take months and months of therapy to kind of get back into a normal caliber. And there's times when it's so stretched out. These are the extreme versions, though, where
Sure.
It may not achieve its original size. But usually, if you kind of address it early on, you can kind of prevent those things from happening. And in a child with sort of a milder version of that, we do these physician supervised bowel cleanouts a lot of times at home with, Miralax and things like that. And the next day, all of a sudden, parents will report to us like, the child just attacked the meal and
Yeah.
had unbelievable appetite one day after the clean out. So that effect can be pretty quick.
Well, and that's true for kids who aren't necessarily suffering from constipation, but tend to be those more hesitant eaters. So I'll go to their home and the parent will say, I don't know what the story is, but he ate like a horse yesterday. And my next question always is, did he have a bowel movement? Oh yeah, it was huge, and it's like, well, that's why. That's why it's so important to keep things moving, literally. But another term that I think parents are becoming more savvy about, and I know we have a lot of therapists listening to or interested in just learning more, is just look at the term gastritis. And that feels like kind of in a way, just an umbrella term to me, but can you just explain what gastritis is and what it can encompass?
Yeah, so gastritis, it really just refers to inflammation of the stomach, and it can be from any number of different things. So it could be in kids, we see an eosinophilic gastritis, which is kind of related to EOE, or where it's an allergic type of inflammation. H. pylori, which is an infection, and worldwide the most common cause of ulcers is this infection with H. pylori, and it's not just in third world countries, and we see plenty of it in the United States. We see plenty of it in Montana, Colorado. So H. pylori infection in children doesn't tend to cause as often the full-blown ulcer disease, but it can cause this inflammation and this gastritis that will give them pain when they eat, especially certain acidic foods and things like that. And so if that is diagnosed and treated properly, again, if it doesn't hurt when you eat, you're going to be more willing to eat more and eat more frequently.
Absolutely. Absolutely. One of the things that you and I have talked about before, and I know it's a passion of yours, is celiac disease. And I was wondering if we could talk a little bit about not only celiac, but also non-gluten celiac, non-gluten sensitivity. So, or not saying that right.
Not celiac. Yes, non-celiac
gluten sensitivity. It's Monday.
And so it's funny because their symptoms can overlap very closely. But celiac disease we call it the great imitator, because everybody always thinks, oh, if you don't have diarrhea, you don't have celiac, and that's totally not true. I mean, I'd say the sort of more common thought of it is that it's a young toddler with horrible diarrhea, losing weight. And certainly there are those kids, but there can be kids who present with constipation. There can be kids who present more with just kind of more vague abdominal pains or intermittent vomiting. So it can really present a whole bunch of different ways. And so the big, I guess, differentiating factor between celiac and gluten sensitivity is that celiac, the gluten is actually causing physical damage to the small intestine, versus non-celiac gluten sensitivity. You still may get diarrhea or constipation or some other, sort of irritable bowel syndrome type of symptoms, but there's not actual full-on damage going on. So you'll feel the symptoms and the discomfort, and it can lead to, again, a whole bunch of different GI symptoms. But the hallmark is that there are really accurate blood tests for celiac, and if you do the endoscopy, you'll actually see the damage. So the little villi that are in the intestines will get kind of stubbed off and sometimes just completely wiped out in celiac, which then repairs itself once you take the gluten out of the diet. And
what's your feeling about a timeline? Let's say that I'm working with a child and the whole family happens to be gluten-free. Does that child, if they're going to get scoped because we're suspecting celiac in the family, do they have to have gluten a certain amount every day for a certain amount of time? Or what's your feeling about that?
Yes. So if they had been gluten-free for a while, it's usually about up to 6 weeks of having some. It doesn't have to be, you don't have to be overloading, but having some gluten in the diet daily for probably about 6 weeks before we would scope. And there are genetic tests that'll tell you if you carry one of the celiac genes. There's one called DQ2 and one called DQ8, but probably 30 to 40% of Caucasians carry one of these genes. So it's a gene that allows for celiac, but it's not a one-to-one. Like if you have the gene, you're not automatically getting celiac. So it's not a good rule to say like, oh, you have the gene, you have celiac, because you're also probably more predisposed to get gluten sensitivity if you carry one of these genes as well. If you don't have either of the genes, then it's nearly impossible to actually have celiac, but you can still get gluten sensitivity. So that's kind of the only time. I think that, excuse me, that genetic test is kind of worthwhile. But yeah, if somebody comes in and they've been gluten-free for a while, and it sort of depends on how strong the family history is, but the gold standard is to have some gluten back in the diet for 6 weeks and then get the endoscopy.
Because we've got to see a little damage being done to make the diagnosis. Is that essentially the thought behind it?
Correct. And which is kind of a hard sell if it's somebody who has awful symptoms. So, and actually the Europeans have changed their view. So if there's a first degree relative, say mom or dad or sibling has celiac, and this child has the labs that were high, or if they have these reactions that are pretty violent when they are gluten exposed and they have a first degree relative, your index of suspicion is pretty high, because of the family history and all that. So then you might not necessarily need to go down that full diagnostic route in some of those cases, but it can help, because to know beyond the shadow of a doubt that the child actually does have celiac can kind of take that question, like, well, maybe I can have a little bit of gluten here and there, kind of bargaining that, especially when they hit the teen years, can sure. really end up doing them a disservice.
Yeah.
And so it does. I think it's important to get the right diagnosis, but there are cases when the family history and some of the lab testing is so convincing that we don't 100% always need to do it, but it's still recommended for almost everybody else, because again, if you're cheating a little bit, and that's different than for non-celiac gluten sensitivity than it is for celiac, because with celiac, then you have ongoing damage. You might run the risk of things like anemia and low vitamin D and low zinc and some other important nutrients like that. So you want to know the difference.
Yeah, you definitely do. And I've chatted with you about this before, but just for everybody listening, it's funny that I couldn't say non-celiac gluten sensitivity, because that's what I've been diagnosed with. So years ago, I they thought maybe I had MS because I was experiencing such severe neuropathy. But that's exactly when I started becoming really interested in working with children with autism. And back then, when it came to feeding therapy, a lot of those kids were on a gluten casein-free diet. So I eat with my kids, and I noticed that when I was eating if I had a lot of kids on my caseload that week at the hospital who had autism, we're eating gluten-free, I actually felt better. And I started to put 2 and 2 together, had the genetic testing, I do carry the gene, but every scope shows that I don't have celiac. However, when I stay away from gluten, and I stay away from gluten 99% of the time, I'm a happy camper. But man, if I accidentally get some, it doesn't have to be a lot, but it really, really bothers me. And I actually start to get the neuropathy in my fingers and in my toes again. So it's so interesting. We're learning more and more about it.
Yeah. And there's a varying degree of how sensitive people are too. So, and for years it was kind of, pun intended, poo-pooed, people would roll their eyes, but it's recognized that it's a legitimate clinical entity, but there's no great diagnostic test for non-celiac gluten sensitivity other than you remove the gluten out of your diet for 4 to 6 weeks, symptoms go away, you re-challenge it, symptoms come back, and you and you've already ruled out celiac. I mean, that's how you really get your answer.
Sure. Well, speaking of sensitivities, what about food sensitivities versus food allergies or intolerances versus allergies? Can we talk a little bit about that?
Yeah, so there's a sort of probably 2 main branches of your immune system. And so everybody has, not everybody, but a lot of people have this mindset where they think, like, if you have tested negative for allergies with either the blood test, which is called an IgE, or a RAS test, or the skin prick or the scratch test, that you then, okay, you don't have any issue with these foods. But that's really only testing for one side of the equation, the what they call IgE mediated true food allergies. But then there's a whole other side of the equation with these other food sensitivities that can be mediated by a different part of your immune system, that we don't have great testing for, but can still cause a host of reactions in the body, including everything from upper GI symptoms to constipation, diarrhea, a whole host of different things. And I think they're grossly underdiagnosed because we don't have a great test for them. And so again, that common mentality that, like, oh, if your blood test for the allergies is negative with the IgE and your skin test is negative, then you can't have a reaction to foods. But there are a whole host of I guess exceptions to that rule, and certainly a lot of the food sensitivities fall under that.
I have a question around that. So with FPIES, that's a non-mediated IgE.
It's not an IgE yet. So it's not a classic allergy, but they think it's mediated by a different part of an older part of your immune system that still obviously has a and so FPIES, which is another one of those interesting things I learned about when I was in Colorado and seeing a couple cases there, which is food protein induced enterocolitis syndrome, which is a mouthful, which is why everybody calls it FPIES. But it's a violent reaction to foods, most commonly when a child is being weaned onto foods, whether that's some dairy, soy, but even oats, rice can be common triggers. And the first couple times the reactions can be a little milder, but it gets to the point where the child has violent vomiting, projectile vomiting, to the point that they go limp and they look like they're septic, and they're usually rushed to the ER, and it's terrifying to see. And then an hour or two later, they just snap out of it like nothing ever happened, and nobody knows what's going on until it happens again. And then, eventually it's a purely clinical diagnosis by seeing this repeated reaction, but there's no blood test that you can do for things like FPIES.
Just based on their essentially behavioral history. And I think that's one of the most challenging things around FPIES, is because it is a relatively new disease that grandparents, well-meaning, and daycare, preschool, they just think the kid has a stomach flu, and they don't actually see the child get that sick until it progresses, and they can often end up in the ER and go into shock, because you said it can be really, really bad. But because nobody's really heard a lot about FPIES before, especially varying according to generations, et cetera, they're like, oh yeah, he gets sick a lot. And then this poor kid has to go through this and go through it and go through it. And it really takes a sharp pediatrician and a sharp pediatric GI like yourself to say, wait a second, there's a history here. There's something else going on.
Yeah. And those things, it takes time, it has to be repeated episodes. And then you have to go through a thorough diet history, and it can take a while to figure it out, even when you're kind of looking for, like, I'm suspicious of this, but until you find out the exact food trigger. And so it's one of those ones that I think is underdiagnosed, but it's slowly, the awareness is getting better for that one.